Good afternoon, everyone, and welcome. My name is Sarah Nolan, and we're pleased that you could all join us for the last lecture in Volume 7 of our No Neuropsychology Didactic series that brings you experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. We're also excited to welcome our new 2023 to 2025 committee members. We would like to thank our 2023 sponsors for their generous financial support for the series. Additionally, we're grateful for our AACN colleagues for their sponsorship and wanted to share information about the upcoming AACN 2023 hybrid conference in Washington, D.C. Even if you don't attend in person, all registrants get access to conference talks online for 2 months after the event. Registration ends soon on May 31st. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content for our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to No Neuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. All right, now it's my pleasure to introduce Dr. Danielle Prevey for today's lecture titled Considerations when Working with Deaf and Hard of Hearing Patients in Neuropsychological Evaluations. Danielle Prevey is a clinical psychologist at Kennedy Krieger Institute Center for Child and Family Traumatic Stress. She is currently conducting psychological evaluations for deaf and hard of hearing children, as well as therapy. Referral concerns include pre- and post-cochlear implant candidates, autism spectrum disorder, and attention deficit and hyperactivity disorder. Current research interests include diagnostic considerations for deaf and hard of hearing children, with a history of autism spectrum disorder, evaluations with pre-cochlear implant patients. Dr. Prevey, welcome, and we look forward to your lecture this afternoon. All right, you should be able to share your slides now. Thank you.
Okay, can everybody see me okay?
Looks great.
Okay, I want to thank everybody, first of all, for being here today. And thank you, Sarah, so much for the introduction. Okay, so disclaimer, I have no actual or potential conflicts of interest or commercial support relevant to today's presentation. So my background was covered in the introduction by Sarah. For the last 2 to 3 years, most common referrals we have seen are either pre or post cochlear implant evaluation and students on the spectrum. So we focus mainly on a pediatric population, but I am noticing now more and more adults, young adults, who are being referred because of the ASL access that we provide. So I'm trying to include some information as it relates to adults as well. So my goal for today is to really touch on a variety of different topics as it relates to deaf and hard of hearing patients. And after today, you will not be subject matter experts in assessing deaf and hard of hearing patients. Certainly not. It is very complex. I, as a deaf clinician myself, am still learning on a daily basis the nuances of that. The goal is really to have more of to present this information more of a positive frame when it comes to dealing with and serving these deaf and hard of hearing patients. So just a few examples of some very well-known deaf and hard of hearing folks in the community. And this is really to illustrate the diversity of the deaf and hard of hearing community, diversity in modes of communication, diversity in terms of educational background. I'm not sure if you recognize any of these well-known individuals on the slide. But my go-to words that I'm going to be using is deaf and hard of hearing to describe a population of folks who might use spoken English, who might use ASL, who might have a cochlear implant, or who might not have any amplification or assistive devices. But that is the nomenclature that the community prefers. So a few quick statistics to give you a frame of reference. 1 in 1,000 babies will be born, and this is worldwide. So it's approximately 4% of individuals less than 45 years of age have some form of hearing loss. By the age of 80, approximately, there is a 50% chance of individuals having some form of hearing loss. And it is the fastest growing number of deaf and hard of hearing individuals are from Spanish speaking families who might, and I've actually been able to acquire a little bit of Spanish in the last few years because of the number of Spanish speaking families that have been visiting my office. So I want to share some terminology that you might see in some of the medical records, documentation, or when you're interacting with deaf and hard of hearing patients. They might share some of their preferred terminology in terms of how they choose to identify. So we have something called capital D deaf or big D deaf, which is a cultural affiliation, being part of the deaf community. Okay. According to the pathological point of view, they technically might be hard of hearing based on their audiogram, but they prefer to identify as what's called big D deaf because they have a strong community and cultural affiliation. Then we have what's called small D deaf, which these are individuals that don't necessarily have a sense of strong identity to being culturally deaf. Then we have the hard of hearing population, meaning this is an individual who has some degree of residual hearing. More than likely, they may use spoken English or they may use two modalities, spoken English and sign. Then we have the deaf-blind community, which involves a visual impairment and hearing loss. And that term, deaf-blind, you're not going to see that typically until later on when we're dealing with adults, because that includes more of a cultural affiliation within its context, okay, when people develop that identity. So these are more, when I make recommendations for the IEP team, I usually recommend using that word because that might reflect that child. Now, I do not encourage the use of the word hearing impaired. It has a negative connotation, and I see that a lot less nowadays, but there are still some people who prefer that for themselves, and that's an individual choice. Cochlear implant user, that's more of a new terminology. Many deaf and hard of hearing people, those who feel a strong affinity to their implant might identify as that. Then we have those folks with unilateral hearing loss, which means hearing loss on one side. Another term you might see is children of deaf adults, which is abbreviated CODA. Okay, these are typically children who are hearing but have deaf parents. I see a good number of those students in our clinic because of the language access that we provide for the parents using ASL. Intersectionality, which essentially, of course, refers to individuals that have more than one identity. They may be deaf and they might be a person of color, or they might feel a stronger affiliation to the Black community as compared to the deaf community. So the development of deaf identity is going to vary from individual to individual that you encounter. So I know it's very easy to feel hesitant and unsure of how a person identifies. So my suggestion is the best bet is to use deaf and hard of hearing because that is pretty much the most universal identity and term you're going to see. Now, when we're thinking about conceptualization when it comes to deafness and hearing loss, I have to admit that during my first 1 to 2 years of clinical work, I always addressed the families with the medical perspective or the cultural perspective. But over the years, I've really shifted my approach and my view of the deaf and hard of hearing individual as more of a spectrum in terms of their presentation. Their presentation is not one or the other. You know, a deaf person can be cultural deaf, but still have some medical concerns that are valid and that we need to consider. A deaf person can also be more strongly affiliated as a cochlear implant user, but there's still aspects of their deaf identity and part of that culture that a cochlear implant user might have. So for me personally, I have really shifted over the last, I would say, 4 to 5 years in the evolution of how I'm viewing them, and I very much see things on more of a spectrum now. So we always have to consider the etiology of a person's hearing status, and we typically categorize this as genetic causes, okay, non-syndromic. Okay, if we're looking at that, that's approximately 70 to 80% of those congenital causes. And then also we have our syndromic causes of hearing loss, which, also can have genetic considerations, and that accounts for about 20 to 30%. Then we also have other factors such as illness and disease. Okay, rubella, for example, which is not as often or as common anymore. Okay, that was much more prevalent in the 60s or earlier than that. However, in some other countries outside of the United States, you will still see concerns of rubella as a possible etiology for hearing loss. So if we have children who have been adopted internationally, if they contract rubella during those developmental years, they could potentially have hearing loss. Now, that number 60%, okay, this can be preventative. So what we need to think about with kids who have chronic ear infections, for example, chronic ear infections are considered as something that can cause conductive hearing loss, which is something that can be resolved with, for example, tubes. You might be familiar with that. But if the infection is chronic, it's going to eventually have an impact on the inner ear and the inner ear functionality, which could cause permanent change to hearing status. And you see that on the right-hand side of the screen. And then you also see that 30 to 40% of all children are identified as what we call deaf disabled or deaf plus. I prefer the deaf disabled term myself instead of deaf plus. It really depends on the context that you're working in. So essentially that means deaf with some additional concerns that need to be addressed. Okay. Here are just a couple of examples of different etiologies of hearing loss. The first one you see is the connexin 26 gene. That is considered non-syndromic because it leads to simply hearing loss with no other comorbidity. There was some early research related to genetic testing, which took place at Gallaudet University. So huge number in deaf and hard of hearing folks at Gallaudet University were identified as having the connexin 26 gene. In addition to that, we have Usher syndrome, which is a vision loss coupled by a hearing loss. We have Pendred syndrome. In those cases, that is related to a progressive hearing loss, as well as a variety of thyroid issues, which you'll see. So the picture you see here on the screen, this is an example of Waardenburg syndrome, the next one, which is, again, associated with hearing loss, as well as that white forelock that you will typically see, as well as the eyes being set a little further apart. And we have a good number of kids who come into my practice who at first blush have some kind of genetic features for that. And I will often refer them to genetic testing. I've definitely worked with culturally deaf families who don't feel the need to get genetic testing in a variety of situations. They feel very comfortable with having a different hearing status. They're not concerned by it. But then later on, when we find out that they have a different reason for the hearing loss, for example, Pendred syndrome, sometimes children with that syndrome, as they enter their adolescent years, they present with a lot of thyroid issues or mood concerns, for example. So it's always good to keep an eye on that. And again, that's why I definitely just want to emphasize that there is a spectrum for deaf individuals in terms of their cultural identity as well as their medical status. Charge syndrome. Okay, so this is an acronym that relates to the possible things that could be affective: coloboma, heart defects, atresia coena. It can lead to growth retardation, general abnormalities, and ear abnormalities. And that is abbreviated. And it's typically related to the CHD7 gene and is abbreviated charge. And as I also mentioned, there are some diseases that can lead to hearing loss. CMV, that's actually the leading cause of hearing loss today. That can come from the mother possibly traveling internationally while pregnant and contracting it that way, or some kind of infection that takes place. So it really depends. A good acronym that keeps in mind to keep in mind when it comes to hearing loss is TORCH, TORCH, referring to the top reasons for hearing loss when it comes to illnesses. We have toxoplasmosis, we have other agents, we have rubella as mentioned, we have CMV, and then we have the herpes simplex virus. Now, two types of hearing loss, or hearing loss falls into two categories: sensory neural, which takes place inside the cranial area, which is typically permanent. And then we have conductive, which is more related to the ear structure and sometimes can be resolved if the reason is, for example, chronic ear infections. Or there are some kids who, for example, children who have Down syndrome typically have truncated inner ear structures. They're smaller in size, which leads to limited access to sound. It is possible for children to have a mix of both sensory neural as well as conductive hearing loss features. And I'm actually going to touch on the newborn infant hearing screening a little later. So we'll pause on that. Now, there are some syndromes that have different levels. And I was recently working with a family of two boys, two patients, both of whom were in their early 20s. And when I observed them walking in the hallway, they had the inability to walk in a straight line. I noticed them bumping into things like the door. No history of visual issues for either one of them. So I did refer them and suggested genetic testing and found out that they actually both have Usher syndrome. Very similarly to Waardenburg syndrome. Some people say that Waardenburg syndrome just affects appearance and characteristics like that white forelock, but there are some different degrees of Waardenburg syndrome that can impact other areas, like, for example, the jaw structure of an individual, which can impact speech and the ability to produce speech. So just some examples and things to keep in mind. So newborn infant hearing screening, as I mentioned. If you compare, as it says here, the 1990s to the 2000s, it's an unfair comparison. It's like apples and oranges because the law related to newborn infant hearing screening wasn't passed in all the states simultaneously until approximately 2001. So prior to that, in the 80s and the 90s, children were not often diagnosed until the ages of 2 or 3 with a hearing difference, and early intervention services were then not initiated until sometimes 3 or 4 years of age. Just an example of some of the language I tend to use when I'm drafting reports. I tend to say things like child first identified with hearing concerns, okay, by the newborn hearing screening. I feel that that's a little less of a blow, first identified, okay, and leads to less crying in my office. Okay, if you compare stats from 2005 to 2020, you'll see a huge difference in the number of babies who are identified. That doesn't mean that more deaf and hard of hearing children are being born. It just means that the screenings are happening earlier to identify those concerns. So we have a 1 month, 3 month, and 6 month process that we hope to see identified by 1 month of age. ABR testing, which is an auditory brain stem response test, by 3 months of age to confirm hearing loss diagnosis. And then the expectation of early intervention to take place by 6 months of age. So the 1, 3, 6 model. Sometimes I see patients who are maybe 15 to 18 months who are not receiving any services, and they are clearly presenting with a hearing loss. So that's important to keep in mind when you're interacting with deaf and hard of hearing individuals, particularly infants. Okay, I want to really quickly touch on cochlear implants. So when I work with the cochlear implant team, which is very close to where my clinic is, one thing that stuck with me, there was a surgeon that actually said that the surgery itself to implant an individual is the easiest part, the surgery. Because people don't realize that post surgeries, the families need to come weekly for appointments for essentially auditory rehabilitation using that cochlear implant. It sounds simple, but it's actually a very complex process for many families. So the cochlear implant has two parts, the external part, which is called the processor, which hangs right behind the ear, and then the internal piece. Okay. So the coil itself has 22 channels. You might be able to see them here. And essentially, it bypasses the structures of the inner ear and goes directly into the cochlea itself to pick up those signals and produce sound. Now, occasionally, a child might not have a typically formed cochlea. So there's a growing field called ABI, auditory brain stem implants, which bypass not only the inner ear structures, but they also bypass the cochlea as well and go directly to stimulating the brainstem. Not a lot of hospitals currently do that surgery in the United States as of yet, however. Okay, just some examples of some very common barriers that can impede implants with or outcomes with CIs. Okay. Again, as my role within the cochlear implant team, a few years ago, the cochlear implant team would refer patients to me if they weren't, for example, making progress with their implant or if there were a lot of barriers that they were experiencing. I would say in the past 2 years, things have shifted, and I'm now seeing families pre-surgery as a very routine type of care. That's becoming more and more common and more standardized. So it's no longer just post-surgery. The shift has now happened to include pre-surgery referral. So some common barriers, okay, are, for example, long stays in the NICU. If a baby stays in the NICU for over 100 days, the CI might not be a priority. That's very high up on the list. Multiple medical concerns, Mondani dysplasia. So essentially, let's go back to our visual. If we look at the cochlea, okay, Mondani means it's only half. So essentially, you have only half of the cochlea instead of having, so you're not going to be able to use all 22 of those channels. And then another common concern is a lack of the auditory nerve, which is cranial nerve 8. I have seen patients who still get a cochlear implant and it doesn't work for them because they have one of these particular barriers. So psychosocial related concerns to successful outcomes are transportation, getting the children to those rehab appointments if the parents don't have transportation or have conflicts with work, for example. Also, a lack of parental understanding and or support for those parents oftentimes are barriers to positive outcomes. Now, here are a few more examples of some other hearing devices. We have something called a bone-anchored hearing aid or a BAHA, which is literally anchored to the bone on the individual's head and causes vibrations that then can be translated into sound. Very common for children who have conductive hearing loss. You're going to see that quite often, and particularly atresia. You also have hearing aids, and because technology is so advanced today, audiologists do have the ability to look at a child's hearing aid and see how many hours that child is actually wearing it. And I think for some adults, maybe tracking how many hours the hearing aid is on, for example, to see if they would be a good candidate for a cochlear implant. Now, I mentioned early unilateral hearing loss as a possible identity. Sometimes an audiologist will refer children to me with unilateral hearing loss, and the parents really don't know why they're being referred because they do have quote unquote one good ear, but there are certainly still some challenges with unilateral hearing loss, localizing sound, for example. Oftentimes, when there's a lot of background noise, they have a hard time differentiating speech. If somebody is talking on the side where the hearing loss takes place, okay? And they have what's called a cross hearing aid, also known as a contralateral routing of signal hearing aid, where it will take the sound from one side and transfer it to the side where they do have typical hearing. Interesting, in some states, Medicaid will not cover the cost of cochlear implants or for unilateral hearing loss. So I do see some changes and some shifts that are probably going to be happening in the next few years, but that's something to keep in mind depending on the state that you're from, is that some things may or may not be covered. I wanted to real quickly give you an example of an audiogram. I keep this in my office and I use it quite frequently with families. So a real quick example, a typically hearing person would be able to hear things like the wind, which is up here, these types of high frequency sounds. A profoundly deaf individual might not be able to hear anything with the exception of maybe an airplane. Really, the key is if you look at what's called the speech banana, this yellow area here in the middle. This is very important information to see if a child's auditory levels fall within the speech banana, meaning can they recognize speech sounds. So if you see an X here, that represents the left ear, and O represents the right ear. This is an example of unilateral hearing loss, for example, on the left side. And you can see they're missing a lot of those sounds that fall within that speech banana on the left side. So sometimes when I'm working with children who are preteens or in those adolescent years and typically don't want a cochlear implant at all, sometimes I will show them this visual and describe it to them so they can better understand, how much information that they are potentially missing. Okay. Now, I do want to talk a little bit about communication modalities within the community. Again, remember, this is a population that falls within a spectrum. There are individuals who might use one or more of these. So we have American Sign Language. Visual language has its own grammatical rules, structure, and syntax. Protactile ASL, which is for members of the deaf-blind community or deaf and low vision community who know ASL. So essentially, this is a person who is using ASL and the deaf-blind individual is putting their hand over their hand so that they can access the information tactily. They will also use haptics on their body in order to convey information in the environment. Cued speech, which is not a language, but more of a communication system that represents phonics and sounds visually. So the difference between map and mat, for example. Okay. On the mouth, they might look exactly the same. Cueing is going to visually represent the difference between that M and that P with mat and pat. Not a lot of individuals cue anymore, but the research does show that cueing does aid in literacy. And then we have the oral auditory individuals. There's definitely a good number of deaf and hard of hearing children who use the oral approach with their education, okay, but not an auditory approach. So it's always very important to remember that just because somebody might have good speech skills, that doesn't translate to equal strength in their auditory abilities. Total communication, which is essentially using, really, it's more of an educational term and an educational approach. It's using spoken English and signing back and forth. Very complicated issue. And oftentimes is not used correctly, but you will see that term come up often, particularly within an IEP. I do want to mention assistive devices. I'm starting to see more and more in my practice providers making recommendations for different assistive devices for deaf and hard of hearing children for whom their speech might not be intelligible or their signing might not be intelligible, for example. I honestly have mixed feelings about this because I feel that that could be further restrictive to that child's access to information, because if you're using a device and then that device itself creates sounds or creates words, y- that child might not be able to access that word because they cannot hear it. So that's something to keep in mind in terms of the type of device. There is Black American Sign Language, or BASL, used specifically within that community as well. There have been some situations where we have had a deaf intern and a hearing intern working together with me in the clinic. And I have to recognize that deaf and hard of hearing patients will code switch. Okay. They will use more sign with that deaf intern. And then with the hearing intern, when they come into the room, they will code switch more to spoken English depending on who they're interacting with. And I think that's an important skill to recognize within our patients, and to recognize the burden that it is in deaf and hard of hearing people who sometimes, when it relates to communication, that becomes a need for them to do. And then within certain regions of the country, okay, there are some modalities that are more dominant. In Northern Virginia, for example, there's a high number of individuals who use cueing. Okay, so you might see that depending on where you're from and where you practice. I think most of you are probably aware that there is a lot of controversy with the modalities to use ASL, to not use ASL. My work is focused on deaf and hard of hearing patients. Therefore, on a weekly basis, I am working with 3 or 4 different deaf and hard of hearing families, and I still see a lot of language delays within patients, even with the advances of technology. And I think it's really important for us to understand that there's a long history of oppression with the use of ASL. So to give you a quick example of that, the Milan Conference, which took place in 1880, quite some time ago, this was an education conference. It was related to the pedagogy of deaf education and deaf teachers, and it really banned the use of manual communication in the classroom. And honestly, deaf education never fully recovered from that. So, my favorite line, my go-to line is, the world is never going to stop speaking. This is often a concern of parents, that if they use ASL, for example, the child will never learn how to speak. But the world is always going to be speaking. You go in and out of a coffee shop, the child is going to be exposed to that. You go shopping at the mall, people are going to be speaking there. So there's never going to be a lack of exposure or opportunities to use spoken language and to be exposed to spoken language. Okay, I'm going to adjust my camera real quick. So this was a very interesting article. Probably one of the first, or in all honesty, very few articles related to sign language and spoken English published in the Journal of Speech, Language, and Hearing Research, which goes back to my point that deaf and hard of hearing individuals and deaf and hard of hearing related concerns fall within a spectrum. So to summarize this, the research found that ASL vocabulary size, okay, can be positively correlated with spoken English vocabulary size. Article also states that while we can't make causal inferences about the relationship between ASL and English vocabulary, the data here are inconsistent with this hypothesis that ASL hinders spoken language acquisition, and is actually more compatible with the hypothesis that ASL fosters and facilitates spoken language acquisition. And here's some examples of the arguments in both camps that were presented within this article. So the first one, arguments against sign language, is that they feel it will harm spoken language acquisition. And one of it comes from the cross-modal plasticity, or CMP, which essentially, the point is that in the absence, okay, of sensory input into an area of the brain that's typically dedicated to auditory information, okay, that information then can be used to process from the other senses, such as vision. Okay. In the case of deafness, visual stimulation can activate areas of the deaf brains that have traditionally been identified as auditory regions. So the argument is essentially that the timing is critical in the reorganization of those neural regions. So essentially, if a child is implanted later on, theoretically, it would be difficult for the brain to quote unquote rewire itself with a when greater cross modal plasticity has occurred. So if too much of that visual stimulation has happened. Studies have shown poor speech recognition outcomes for those who have that greater cross-modal plasticity, or CMP. Now, my interpretation of that is that there are certainly other factors, okay, that can contribute to poor outcomes in later implantation. So really, we have to be very careful about how we're interpreting this data. Another argument out there is called the quote unquote visual takeover hypothesis. Which is another way of framing that. And then Marshak says, and this is another potential argument in that camp, is that children who learn multiple languages get less input per language, which then translates into negative fluency. So I'm adding this section because I think it's important for us as practitioners is to think about, for example, I mentioned earlier, we have a large Spanish speaking population within our community. So we have to look at it. Is it a question of learning ASL? Is it a question of them learning English? Okay. I'm not fluent in Spanish myself, so the child should not have to pick between any of those three. And that becomes certainly a concern of the parents. And then, of course, the same article talks about how sign language can support spoken language acquisition. The first, of course, being the linguistic interdependence and transfer, which essentially shows that there's some research that says, it's a strong predictor, learning sign language, of written language skills later on. And then, of course, learning of sign language prevents language deprivation in children. We see children who have experienced language deprivation, which often leads to cognitive delays and other language issues, making it harder for them to learn because they don't have that foundation of a language. And again, let's talk about language deprivation. We've mentioned that several times. I'll admit it took me a while to feel fully comfortable talking about the issue of language deprivation. Basically, what language deprivation is the experience of lacking full accessible language input. Okay? So it is a new term that has come into the field, and it's referred to as language deprivation. And I think it's important to remind ourselves about intent. Parents do not wake up one day and say, I am going to intentionally deprive my child of spoken language or ASL. Okay. And I think that's important to be cognizant of when we're interacting with families. So language deprivation does impact, as I mentioned before, cognitive development, social emotional functioning, and ultimately educational or school readiness in children, which could translate to parents putting all their eggs in one basket, essentially, and not using any ASL during those developmental years with their child. That could be 6 months to 4 years of age. And then they're not making good progress with the cochlear implant. And then finally, they turn to ASL later on in that child's development. And I would consider that example a case of language deprivation. We now have a child who's coming into my office at the age of 4 or 5 with a lot of behavioral issues because they cannot communicate their wants and needs. Am I going to sit down with the parents and say, FYI, your child is language deprived? Absolutely not. I'm not going to do that. So that concept of language deprivation is more of a framework. Okay. It's more of a conceptualization. We also have the opposite issue. I have parents come in that say, oh, I've read about language deprivation and I think my kid has that, and do some self-diagnosing. But that child might have charge syndrome, for example. They might have an intellectual disability. They might have a myriad of other issues above and beyond hearing loss that we have to address. Okay. Real briefly, I want to speak a little bit about educational methodology and pedagogy for deaf and hard of hearing. A lot of students are mainstreamed in typical public schools with no support, no IEPs or 504s. Then we do have students who are mainstreamed with the addition of an IEP or 504 plan. Depending on where that child lives, they might have a county deaf or hard of hearing program that they attend. Okay. Or there might be a school where all of those children go to be served. Now, you might have heard some things out in the ether that deaf schools are closing throughout the United States. Okay. Now there are more day schools versus schools that have dorm programs. So the number of deaf schools has stayed the same. It's just there are less residential programs and more day programs. Day programs meaning those students commute back and forth from home every day versus living on site. And then, of course, we have Gallaudet University, the only deaf liberal arts university in the world, and then Rochester Institute of Technology, which has a huge population of deaf students as well. And I would say a growing number of universities out there have disability offices or student support offices, and there's a greater awareness, even at traditional colleges and universities, about how to serve deaf and hard of hearing students. Now, going back to schools for the deaf, some follow an oral pedagogy or methodology, some use ASL. It's very much dependent on that particular program. Now, before working with any deaf and hard of hearing patient, there's some things that we need to consider as individuals. We need to unpack our own biases. I know definitely myself, I am biased. I've been biased against ASL. I've been biased against cochlear implants. I've seen both sides of the coin. Again, it is a spectrum, and it's very much dependent on where you are in that moment. And it's very important to unpack any biases you might have before working with any of these individuals. We are starting to see a growing amount of discussion about the definition of the word neutrality. Okay, neutrality can be a positive thing, but at the same time, our job is to make sure that parents are well informed of all their choices and their options. There are some hearing parents who I have had tell me, oh, I'm not getting my kid implanted because I want to be very respectful to their body. So there's definitely conversations that we need to have about these things, the pros and cons, the benefits, and the possible risks that come with cochlear implants, for example. Okay, another quick example of a case study. I saw an 11-year-old patient with a medical history of bilateral sensory neural hearing loss and Mondini malformation. Okay. They were bilaterally implanted at 15 months on both sides. However, one cochlear implant device was not successful. They had to have a repeat surgery. They received early intervention services at the age of 9 months. So they had good access to intervention services. They started at a school for the deaf, okay, and eventually transferred to a mainstream program with an ASL interpreter in a public school setting. Okay. Now, this individual uses spoken English to communicate. So when she came in for her testing, we had to review the audiogram to see how much spoken language they could actually access. And there were a few big differences between their performance on audio-based versus visually-based tests. Definitely there was a marked weakness in those auditorily based tests versus the visual ones. So we were able to justify the need for more visual supports in this case in her school environment. And again, always we come back to that spectrum. Okay, I think we've already touched on many of these points. One thing that I do want to point out, there have been a lot of changes and evolutions within the field of deaf and hard of hearing. That can be education, that continues to go through changes. That can be in terms of communication modalities. That, of course, can be in terms of technology with the constant advancements in technology. Hearing aids now, for example, can sync with Bluetooth. So it's really important to keep abreast of all the changes and all the new information that's coming out in the field. Now, there are some cases where we've had to use ASL interpreters for testing purposes. I tend to use the language ASL interpreters are used in my documentation to facilitate communication between deaf and hearing persons. So this is typically the phrasing I use. When you're having long, for example, all-day appointments, there are some agencies that might request a team, which means 2 interpreters who will switch off at certain intervals. I personally prefer 1 interpreter because they typically have the institutional knowledge and the background information. You can look for certified interpreters, just as psychologists have licenses and certifications, interpreters have in kind. There are some situations where patients might have very limited language. Okay, in those cases of language deprivation, for example, where you might need to request what's called a CDI or a certified deaf interpreter, which is a native deaf sign language user and is very beneficial, for example, clinical interviews. And it sometimes with testing can be a challenge. So depending on your situation, they can be very useful and might need to be requested. You always want to document in the body of your report that, for example, an in-person ASL interpreter was present. This is examples of the language I typically use in my reports when an interpreter is used. Sometimes when we review previous reports from other psychologists, I envision a patient that's not using ASL, and then I arrive and find out they are an ASL user. Okay, the language that they use is always very important, so you want to make sure that's documented. So here's a list of some common referrals that I see, as I mentioned previously. Pendred syndrome, seeing a lot of referrals typically. They come in at maybe 10 or 11 years old because they're starting to show that progressive hearing loss. It's becoming marked, and they might be a benefit for, or they might have used and gotten benefit from hearing aids that are no longer working for them because their hearing loss has progressed to a point where they might now be a candidate for a cochlear implant. That's a huge jump for a lot of them. Okay, so that's a very small population that might need some additional support as it relates to the cochlear implant process because they're moving from one type of device to another. Autism, definite increase in terms of the percentage of deaf and hard of hearing children that we see who also present with autism. And an example of that is they might not, when we look at typically developing deaf children, how they recognize facial expressions or mimic facial expressions might change if they are on the spectrum. And that, of course, can impact their communication and their social skills. Considerations we want to think about when we're doing any type of assessment. Okay. So, visual versus auditory-based learning. And I do see a big difference when I do a list versus stories. Okay. So, for example, a rabble, which is repeating of sentences and then story memorization. Because of the context, children typically do better with that than with single lists of things, for example. When you're doing assessments with students who use sign language or children who use sign language, it is important to remember that these are hearing normed most of the time and that they're measuring English-based knowledge like vocabulary. When you're thinking about learning impairments in reading, for example, it doesn't make sense to diagnose that if a child hasn't used hearing aids until they were maybe 8 or 9. So that's a situation where I would defer the diagnosis at least a year to see if the intervention is successful for improving their literacy skills, for example. A very, very common thing I see, okay, is adaptive. Their adaptive skills tend to be lower. Their adaptive independent skills tend to be lower. I've had parents tell me, for example, that, they might have a 12 or 13-year-old who's not allowed to, go to other people's houses without parents and things like that. They're not locked in their house, of course, but, their skills when it comes to adaptive functioning tend to be a little bit lower. So when I review the ABAS, for example, which I always read through the questions, I often have follow-up questions that go along with it when I talk to those parents. Now, if we're talking about other concerns, auditory or visual fatigue happen. The office that I use has a white noise machine. So for some reason with my cochlear implants, I miss too much information. So that's something to consider because it blocks that information. Making sure that you find a place that is very quiet, making sure that they have access to all the information. Okay. I use an enlarger. And I typically enlarge materials for our deaf-blind patients, for example. And there are times it can be uncomfortable at first. For example, when you have a deaf-blind person who you might be using, sighted guide width to get from one place to another. It takes a little bit of getting used to. Always face the patient. Now we are no longer using masks anymore, not here anyway. I don't know about other places where you might work. Document if masks are used because that can make a big impact. A lot of deaf and hard of hearing patients struggle when there's masks. I tend to include a lot of observational information. Were they looking at us, for example? Do they look when we call their name? Do they hear environmental sounds? Do they tend to ask for repetition or do they tend to sit back more quietly? Okay. Communication styles is another thing we need to think about. Some children have been going to speech language therapy for so long that, how do I say, they're almost scripted in terms of what they do or do not discuss, their conversations. Or if I ask them a question point blank, they will try to evade answering that question. Okay, so definitely document if you see those things. Okay. When you're working with an interpreter, for example, address the individual, the patient directly. Don't say he or she. And I have Okay, and now just checking the time, and there are a few other things that we use. Okay, the DAS, for example. Some examples of ASL related testing, ABC tasks. Everybody knows the WISC. Okay, for example, there is actually a 2-page write-up related to standardizing it and norming it for deaf and hard of hearing children, norming the scores. So if you look at the manual, and I think I saw a question related to that, so it is in the manual. I think I should probably stop now because I want to be cognizant of time. So real quickly, when you're thinking about diagnostics and diagnosis, it's important, as I mentioned before, to consider the etiology, okay, that patient's history of hearing loss, the access they may or may not have had to early intervention services, devices, and language accessibility. Okay. Etiological considerations that go above and beyond just hearing loss. And I can send you the PowerPoint. There are some recommendations that we typically have for working with these families. For example, more involvement with deaf and hard of hearing, programs. There are summer camps. It's important to reduce any type of social stigma or a negative connotation to deaf and hard of hearing. For example, if they go to speech therapy, try to frame it as something positive versus something that the child is not going to enjoy or something that has a negative connotation. Two books that I use very often with the children that I work with pre-cochlear implant surgery. So these are just 2 examples of books that we use very often. And these are some classroom very specific accommodation and recommendations. So on the Hands and Voices website, if you check out their website, this provides a good example of resources that we refer. It's a good example of a resource we refer parents to, that website. It provides things like self-advocacy checklists, information about FM systems and Roger pens, teachers of the deaf and hard of hearing. Okay. Some schools have them within a school. Some schools have an itinerant that works within the county and goes to multiple locations and works with multiple students. Support for literacy, the Orton Gilliam Project, for example, visual phonics systems. For speech and language evaluation, I like to recommend speech language evaluations to be done in noisy environments to see how much they're accessing in a variety of different settings and not just in a quiet office. Things like preferential seating, and then, of course, different modalities, ASL interpreters, cued speech translators, and other accommodations. Now, when a student reaches a college level, here are some additional things, as well as workplace recommendations for those adults. So this book, it's called True Biz. I feel this is a really great representation of what's going on in the deaf community today in 2023. Strongly recommended reading for everyone. And then, of course, I'm not going to read through my recommendations. So just those are some other recommended readings. And that leaves us with about 5 minutes to spare. So I think I did it.
Awesome. Thank you so much. That was a great presentation. Really enjoyed that. We do have a few questions that hopefully we can answer in the time remaining. So the first question that we had was about resources that are available to PhD students or students generally who have a background in ASL and want to learn some of the terminology that you would need to use it in a medical or psychological setting.
Okay. Come to KKI to do your internship. Shameless plug. That'll get you what you need. So there are actually a variety of different social media Instagram accounts related to deaf therapy services that use very specific terminology specific for, therapy in American Sign Language. And I also think there are ASL classes that focus specifically on psychological related academy or information. So ASL Connect, for example, at Gallaudet University also provides information and vocabulary specific to those fields.
A kind of addition
Okay,
to, oh, sorry.
No, go ahead. Oh, I was just looking at, go ahead. If you want to.
Okay. Addition to that is, would you recommend people who are not fluent in ASL, like learning a little bit to kind of, at least be able to introduce yourself, kind of build a little bit rapport with
Oh,
patients?
absolutely.
Okay.
Absolutely. Definitely. No question.
Awesome.
With some of the deaf and hard of hearing students that I see, they have told me that they really appreciate it when, for example, the intern knows how to sign even a little bit with them, enough to say, hi, how are you? Or, do you need to use the restroom or things like that? I think it creates that warm environment and that rapport for that patient. I've also seen the opposite issue as well in some cases where there's an individual who might be conversationally fluent in ASL, but they jump into doing diagnostics or testing when they're not really ready for that. So again, we all need to do some unpacking and see where our skills actually lie. But to have a very just introductory or superficial conversation, I think that's nice because rapport is very important when we're interacting with our patients, right? So
Yeah. So you mentioned a little bit about this, but to follow up on a question that someone had about norms for deaf and hard of hearing on traditional neuropsych tests, what do you recommend there? How can people find these to be able to use them? Any test, and they also added any test that cannot be used.
the ADOS 2 in the manual, and that's an autism screening. In the manual, it will say that it is not encouraged to be used with students who use ASL or children who use ASL. And another provider has actually told me that they don't use the ADOS for children who use spoken English either. Okay, so just that one's one to be avoided.
And is there other tests that you'd recommend using that have good norms? for this population?
The WISC, or the ADOS, ADOS.
I
That's
think
the only
someone
one I
had a
can think of
question.
right now. Mhm.
Yeah, someone was having a question about the spelling, I think, so I'll respond to that. All right, well, I think that is about recommend we wrap up there before we dive too much into another topic. But thank you so
Actually,
much.
real quickly,
Oh,
I just
sorry.
want to add real
Okay.
quickly, the question about bilingual adults. I saw that one.
Uh-huh.
These are just my qualitative observations. Okay. There's no empirical evidence to support this. These are just my observations. But I've noticed that adolescents, young adults, teenagers who use both American Sign Language and English typically have very, very rich vocabularies. They have a very strong lexicon. Okay. And they code switch very well. But to learn American Sign Language as a second language might present a little bit differently.
All right, great. Well, we'll wrap up there today. Thank you so much for your presentation. That was really informative, and we appreciate
Of
it so
course.
much, you being here.
Thank you for inviting me, and thank you everybody for being here. Appreciate it.
Yeah. Thank you, everyone. Have a good rest of your day.